Welcome in, everyone. We will get started in just a minute. Waiting for everyone to come in from the waiting room. Thank you for being here this afternoon or this morning, depending on which time zone you're in. All right, I think a good amount of people here are joining us for this PHA Live webinar today. So thank you again. My name is Angela, and welcome to the PHA Live webinar, Pediatric to Adult Congenital Heart Disease, Managing Your Diagnosis. Also, we would like to take a moment before we get started to thank our sponsors, J&J, for their support of this program. Please note that sponsors do not participate in the development nor endorse program content. Additionally, consider joining one of the largest organizations focused on research and hopefully to find a cure for pulmonary hypertension. Professional members also will have access to online medical education, mentorship programs, access to research grants, as well as early discounts on event registrations such as PHA 2026 or PHPN Symposium. If you are interested in membership joining PHA, please reach out to memberships@phassociation.org. And lastly, just one programming note. We do have Q&A during this webinar, so please feel free to use the Q&A button on your toolbar to submit questions to our panelists. They will be able to answer those at the end of our webinar. Also, there will be a very brief survey that will pop up once we do conclude for the afternoon. So please take a moment to fill out and complete that survey. That helps us to know what program you would like to see in the future. And now we will go ahead and start our programming, our webinar. I would like to welcome our panelists and invite them to introduce themselves. We'll start with Dr. Palutla. If you would take a moment to introduce yourself.
Yes, thank you so much, Angela. It's really nice to be here with all of you today. My name is Priya Palutla, and I'm a cardiologist at Harbor UCLA, which is a public hospital in Torrance, California. My background is, general adult cardiology, but I did extra training in adult congenital heart disease, so that's really my passion. And I also take care of women who have heart disease, as well as older children and teens and adolescents who are moving to the adult world. And my involvement with pulmonary hypertension is chiefly from the adult congenital heart disease lens. And so I manage a lot of patients who have PH from their congenital heart disease, but I also care for patients who don't have congenital heart disease, who have PH. I'm one of our faculty for our PH clinic here. And I am like an investigator for some of our clinical trials that we have ongoing for pulmonary hypertension. So thanks so much for having me. I'm looking forward to engaging on this topic.
Thank you so much. And Dr. Kreiser?
Thank you, Angela. It's great to be here with everyone this afternoon. My name is Paul Kreitzer. I'm a pediatric cardiologist in Cincinnati Children's. I take care of children with congenital heart disease, as well as kids with pulmonary hypertension of all causes, those with congenital heart disease, as well as those with pulmonary hypertension due to other reasons. And I think we're really excited about this topic today. Certainly in my role, I help care for babies, for children, for teenagers, and for young adults with pulmonary hypertension. We really do see the spectrum as these kids grow up and they become adults and then transition their care into the adult world. So I think this is a very timely topic to talk about. And just to reiterate what Angela mentioned for those who are joining us a couple minutes in, this is meant to be a session to hopefully get you the information that you're looking for. So we have a live Q&A, please. As we're talking and the question comes up, type it into the chat and we will do our best to answer everyone's questions. So I think we would like to start today just talking a little bit about pulmonary hypertension. of all causes. We're going to focus really most of our discussion on congenital heart disease, but pulmonary hypertension can arise due to a number of different conditions. And really those conditions change across the lifespan. When we care for kids, we think about them and what might be causing their pulmonary hypertension differently when there are babies or infants who are first born, when there are children, and as they grow into teenagers and adults. And this holds true for congenital heart disease as well, that really are infants or babies with congenital heart disease, if they have pulmonary hypertension. It tends to be different forms of congenital heart disease than those that we see when they're in school age or when they're older. And we'll talk more throughout the session about the ways that we diagnose pulmonary hypertension in babies, children, adults with congenital heart disease, and the different strategies that we have for treating them. And that really depends on the specifics of each case. Patients with congenital heart disease can also have other causes or contributing factors to pulmonary hypertension. And those are all important when we're thinking about what sorts of studies do we need to do for diagnosis, what is the right therapy, whether that involves medication, whether that involves interventions, be it surgery or procedures like a cardiac catheterization. And that treatment plan really becomes individualized. So our goal is to talk about all of those things throughout the session today, and try and give you that broad spectrum of how we approach patients based on where they're at and the type of congenital heart disease that they have. And Dr. Palutla is going to talk a little bit more about these other factors or other types of pulmonary hypertension that you can see in kids and adults who have congenital heart disease.
Thank you. So I'm interested. I'm sure people are wondering, like, when you look at these, Dr. Kreitzer, like, there's so many causes. You can see that in adults, these are all the ones that most of us, probably are familiar with in the PH world, like left heart failure and, IPA, IH. How do you kind of go about deciding which of these things a child has?
Yeah, it's a great question. Almost all of our kids that we're seeing, either by the time we see them or when we're seeing them, we're doing testing, including an echocardiogram, really to look at the heart. This is a test, an echocardiogram, that's done commonly for diagnosis and monitoring of pulmonary hypertension. But for patients with congenital heart disease, it's really helpful in understanding what is the structure of the heart, how did it develop, are there extra connections, are there holes, are there parts of the heart that didn't grow or develop normally during development. And those tests, like an echocardiogram, may also be supplemented with additional types of testing, like a CT scan of the heart or the lungs, a cardiac MRI, to give us additional information about the particular type of congenital heart disease, about how much blood is flowing through the heart, whether or not there's shunting or blood crossing the sides of the heart that we don't normally see, and then helping us plan for what we think the next steps of care are.
Yeah, and I guess I can kind of take it from there in terms of adults. So in adults with pulmonary hypertension who have congenital heart disease, it can be really complex because there are a lot of different causes. Before I get to this slide, I would say that the vast majority of patients who have pulmonary hypertension who are adults have some kind of shunt, and that's a fancy way of saying there's a whole connection somewhere and blood is going the wrong direction and it's going from the left to the right. And so eventually with time, there's just too much blood flow into the lungs and the right side of the heart, and that leads to pulmonary hypertension. And the most severe form of that is what's called Eisenmenger syndrome. As time has gone on, I have seen fewer and fewer patients with that. If they were born in this country, we tend to diagnose patients earlier now. When I started my training and I started out in practice, I had a number of patients with this. And as time has gone on, there's fewer of them. I have patients now who were born in other countries and were unable to get those holes closed, or even were not diagnosed until their 50s or 60s. And so that is sort of the most severe form. But, there is also a category of patients who have the hole closed and they can still develop pulmonary hypertension. And that is, I think, one of the really vexing parts of my field is even when we fix the defect, they may develop pulmonary hypertension, or sometimes they have a very small defect and they still develop pulmonary hypertension, and it can be really confusing to figure out whether this hole that looks like it shouldn't do anything is causing it, or if they have other things. And so those are sort of, they all kind of fall into group one. And the helpful thing about classifying them is group one are the patients who are eligible for the treatment, the treatments that we have is really helpful. They might also have disease due to, left heart problems. And so that's really complicated, but it's things like heart failure, a valve issue, congenital heart disease that affects the left side of the heart. And then this was on Dr. Kreitzer's slide too, but there might in adults or children with congenital heart disease, the mechanism, the way it arises can be very different in that there might be a mechanical cause. And so in adults who have sort of typical group 1 pulmonary hypertension, some of you might be aware, it might be like the smooth muscle proliferation, and the arteries are filled with muscle, or they get smaller. This is where there might be like a piece of tissue or a membrane, something that's mechanically occluding it. And then finally, there's this group 5, which is, we don't know. Essentially, these are really complicated patients who may only have one pumping chamber of the heart, or they may even have pulmonary hypertension in one part of the lung and not in the other. And the treatment of that is complicated. I kind of talked about this already, but this is the group that I think is really confusing. It says pulmonary hypertension with a small or a coincidental defect. And that's just a fancy way of saying like they have pulmonary hypertension and they have congenital heart disease. And you would not expect that hole or issue to cause a problem, but it does. And then I mentioned this other category too, also very vexing, in which we think that we fixed the problem and then they come back with pulmonary hypertension. I have several patients like that where the hole was fixed and we're like happy and the patient's happy and they come back and now they have pulmonary hypertension. It's a really unique thing to our field. So I see a question in the Q&A. And I encourage all of you, like Dr. Kreiser say, like, please give us your questions, because we really envisioned kind of an open, a conversation between all of us. So the question is, my 10-year-old son was diagnosed in May 2024 with pulmonary hypertension, investigated with echo, CT, and blood work. He also has PAPVR, which is partial anomalous pulmonary venous connection. So this is where the pulmonary veins drain into the wrong side of the heart. We are awaiting catheterization. He's currently treated with sildenafil and Lasix. Are there any insights on PAPVR and PH in children? So this one's for Dr. Kreitzer.
Yeah. So it is a great question. And I think one of the challenges that we often face with children who have congenital heart disease and they have these abnormal connections or they have these shunts or holes in the heart is helping to sort out whether or not it's safe to have surgery to fix those connections or to close those extra holes. And most of the time we know about the congenital heart disease early in life, and it's a easy decision to move forward with doing surgery. Sometimes, as Dr. Blutla mentioned, even when we do surgery at the normal time, everything goes exactly as you would hope. Children still develop pulmonary hypertension afterwards, despite our best efforts. But we know when kids are older, when they get diagnosed with congenital heart disease, certainly by the time they're in school age, that there's a higher risk that they may have pulmonary hypertension, and that pulmonary hypertension may make it riskier or harder to have heart surgery to fix that connection or to close that hole. And part of that evaluation is going through a number of tests. And it sounds like your son has had some of those already to help really understand what the congenital heart disease is. And then the cardiac catheterization really gives your team the best information about exactly what's going on with the pulmonary hypertension for your son. And they can help you interpret that information to know whether or not it's the best option and the safest option to have surgery to fix that PAPVR, or whether or not continuing to use medicines are the best option. This PAPVR, this partial anomalous pulmonary venous return, meaning that some of the veins that come back from the lungs to the heart aren't connected in their normal arrangement. That is something that we see commonly, and it is one of the CHD diagnoses that we see in kids when they're a little bit older, meaning after their firstborn or in infancy. Oftentimes, we're able still to treat them with medicines and do a heart surgery. But to know that, you really need the heart cath to make the best decision. It looks like
So
we
I
have.
guess putting on, oh, go
Go
ahead.
ahead.
I was going to say, Dr. Kreitzer, like putting on my, the hat of a parent who might have a, as a child with this, like, what do you think parents can be kind of doing, and what are your recommendations for a parent whose child has maybe not PAPBR but some kind of pulmonary hypertension, associated with a congenital heart lesion? Like, what can they kind of expect might happen?
Yeah. So the steps of what you can expect is that your treatment team should help you through the process of, one, understanding what the diagnosis is. Congenital heart disease comes in many different types, and it can be certainly overwhelming to get that diagnosis, particularly for kids who are a little bit older and have seemed to have been doing very well. And then help you understand what those tests are that are going to get the information to make a good treatment plan. In this particular case, it sounds like there's a plan in place for a heart cath, which is really the right next test. And after that heart cath, you should be able to sit down with you, review the findings of the cath, and then make those decisions going forward. Sometimes after the heart cath, the team's able to say, we do think surgery is the best option. Sometimes the recommendation is going to be, we need to do more medicine and then even repeat a heart cath after a period of time to see how things are changing. And for some kids, the best option is going to be to continue medicines for pulmonary hypertension. And you should really expect your team to help you along the way and understand and interpret that information and give you recommendations as you go. It's hard to wait. Oftentimes for our families, the hardest part is waiting to get that information.
And in your experience, like, does that pulmonary hypertension like ever go away? Because I think it's a unique scenario when it's associated with congenital heart disease, in which it might not have the same course. So I think maybe helpful for our attendees to hear a little bit about how it might be different from, group 1 PH in a 50-year-old woman versus PH in a 10-year-old or 2-year-old who's got a lesion that might be corrected.
Yeah, that's a great question. And really we see both of those things happen. For most babies, young kids who have congenital heart disease, even if they have pulmonary hypertension early on, most of the time, but not always, we can safely do heart surgery. And after we do heart surgery, over time, that pulmonary hypertension gets better. It may take months to a few years. Kids may continue to benefit from being on PH medications, but most of the time it gets better. As we mentioned before, sometimes pulmonary hypertension sort of comes out of the blue after you've had heart surgery, and then we can help deal with that as needed. As kids get older, the risk that the pulmonary hypertension won't get better increases. Unfortunately, there's not a perfect prediction. I've seen both cases. I've seen kids who are 10 or even a little bit older, where we do all the testing and we're able to do surgery, and the pulmonary hypertension does get better. And I've also seen times where kids come in around this age, and at that point, the safest thing is to not do surgery, but to continue using medicines to treat the pulmonary hypertension.
And just to go ahead.
Oh, go ahead.
I was going to say, just to piggyback on that, I have seen the same thing in adults. So I had a patient once who came to me with, she was coughing up blood, had really severe pulmonary hypertension. It was like her pressure was like 130 or something, and she had a mechanical obstruction. And so when it was removed, her pressures became normal, and she was off meds within a year. But I also have seen the opposite, in which you do fix the issue and it doesn't necessarily go away. But I think that overall, I would say, at least for adults and maybe in children, I think compared with group 1 PH in a middle-aged adult, I think the prognosis it can be in some cases better. depending,
Yeah, I know I will often talk to families about sort of three options after doing the heart cath. It's sort of a stoplight system of a green light, yellow light, red light. A lot of the times it's a green light. Everything looks good for a go for heart surgery to close the shunt or the hole or fix the connection. Sometimes it's a yellow light that we need to be cautious and we may need to continue medicine and retreat. And this happens a fair amount. And then in some kids, it is that sort of red light. It looks like it is just safer to continue to treat with medicines. And I think that's a good way to think about it.
We have a question in the chat, which I think I can answer. And the answer is, how often do you do genetic testing in your adult patients? I'm wondering how many of your patients who present with PH after a CHD closure may have a genetic mutation, which links both diagnoses. That's a really good question. Yeah, I am a big proponent of genetic testing. I'm in a county hospital, so I have been working to streamline that referral process. But I think your question is a really interesting one, because I have been sending them out, but mainly with an eye towards the congenital underlying diagnosis. So do they have a syndrome or do they have a mutation? But should we be also testing? I think that's a really good point. What happens, I don't know how many of you have been to genetics, but at least in my world, when you send them to genetics, you have to direct the question. You have to say, I'm wondering if they have, for example, a syndrome, and then they'll test for those things. But you're making me wonder, and I don't know that anyone's looked into this, into whether those patients who are having these recurrence of pulmonary hypertension after a defect is closed, or those who have a small defect, but they have too much pulmonary hypertension is unexpected. They may have genetic defects. I think it's a really excellent point, and maybe something for us to think about. And there might be underlying genetic defects that actually are causing the pulmonary hypertension, which is not explained by a hole or something like that. It's a great question.
And we have, in general, for all of our children who have congenital heart disease, we are sending genetic testing, as you mentioned, to look for sort of other syndromes or conditions that may be associated with the congenital heart disease. And certainly that's true also for our patients with pulmonary hypertension and congenital heart disease, that we are also recommending genetic testing. Not all of them are going to have a gene that explains the pulmonary hypertension, but we do know that there are some gene mutations that are associated with forms of congenital heart disease. Some of them just the simple or small holes in the heart, things like SOC17 or TBX4 may have an ASD connection between the top chambers of the heart, or a PDA, a connection that's normal in all babies between the lung arteries and the aorta, that lets the blood skip the lungs before babies are born and the lungs aren't doing any of the work of breathing. That may stay open in children who have these gene mutations.
So in your institution, Dr. Kreitzer, are they sending, when you send a patient to genetics, do they automatically screen for the underlying, for potential pulmonary hypertension associated mutations?
Yeah, Dr. Plutlatz, and just as you mentioned, when we're having families meet with our genetics team, we're often talking with the genetics teams ahead of time to let them know what our questions are so they can help direct the testing. And for our kids who have congenital heart disease, we're really asking for both. We're looking for other syndromes that could be associated with the congenital heart disease, but also making sure we're looking at genes that could be associated with pulmonary hypertension.
Great to know. I see more questions. Okay. I think I did that one. Here's another question. I have a genetic mutation, SOC17, which links my ASD and pulmonary hypertension. I had to ask to be tested because I was originally diagnosed with IPAH. I was 34. I went my entire life without being diagnosed with ASD, which is why I asked this question. The SOC17 is still new. A lot of doctors aren't familiar with it. Yeah, that kind of summarizes everything, right? Like we know now that there are genes that are associated with pulmonary hypertension. And I will say atrial septal defects in my world very commonly is diagnosed in adulthood. Like I have 20-year-olds, 30-year-olds, 40-year-olds. I have 60 and 70-year-olds. Because if it's the murmur can be fairly subtle if you're not listening for it. There's like a exam findings that many are not necessarily well versed in. And if you even, it can be missed on echo if you're not really paying attention. I would say not so much in pediatric cardiology, but adult cardiologists, if they're not really as skilled, definitely there are many patients who are in their 30s and up who are not diagnosed as adulthood. But yes, and in fact, I would say most of my colleagues don't know what SOX17 is. But it's important. And I think there needs to be better education, because I think putting the burden on patients to tell the doctor is probably not really fair or reasonable. Like we should be more aware of those things. And as genetics is always evolving too, as we move along, like they find new genes and then the genetic panel becomes bigger and there are more things to test for. And I think hopefully as we move forward, there's going to be more targeted therapies. Dr. Kreiser, I bet you have more experience with SOX17. I'd love to hear what you have to say.
Thank you. I will just say I agree with you that pulmonary hypertension is rare, and some of these types of congenital heart disease are relatively common. So we see lots of kids who have an ASD but don't have pulmonary hypertension or don't have SOX17. So it is that there's always that challenge of being able to identify those kids or adults who need extra testing. We do have a number of kids that we care for with SOX17. And we are learning more about it and how children and adults with SOX17 can be a little bit different than other types of pulmonary hypertension. And we have seen some differences in how the blood vessels in their lungs have formed, at least in kids, which is important to know about and does help us tailor our treatment to be specific for those cases. Just as the person who
I'm curious. Oh, go ahead. Sorry.
Just as the person who put the comment in there, it is a newer gene. So even those of us who know about it, we're still learning about it and learning how best to care for patients with SOX17 and pulmonary hypertension.
I'm curious to know, like, when you find a patient who had, like, I think this, our chat participant that's a really good question, because as Dr. Kreiser said, most patients with ASDs don't have pulmonary hypertension. And it's really, I would say the thinking on that particular process, an atrial septal defect, which for those of you who aren't aware, it's a hole in the upper chambers of the heart. The thinking is now, at least in adults, has shifted away from that it causes pulmonary hypertension, at least in my congenital heart disease kind of community. So I think it was a really smart call to check for it, because it makes more sense. But I'm wondering, like Dr. Kreiser, if you have someone who has a SOX17 genetic mutation, and I'm only mentioning this one mutation because we've had several questions, both now and also in advance of this webinar, like, what do you, does it change your management or your thought process at all?
Yeah. I would say ASDs, or these holes in the top chambers of the heart, are often types of congenital heart disease that we're just watching for the first few years of life. We don't expect it to really cause kids problems with how they're doing or growing. And we're waiting until they're a little bit older to see whether or not we're seeing signs of extra work by the heart, that the right side of the heart is getting bigger, to make a decision of, if we need to close it and how to do it. It is helpful to know if a child has a gene mutation associated with pulmonary hypertension like SOX17, because that may influence whether we recommend to close it or not. As you mentioned, Dr. Plutla, we don't think the ASD is causing the pulmonary hypertension, even in these patients with SOX17. It just seems to be an associated finding. And for some patients, having a hole between the top chambers of the heart can actually be helpful. If their pulmonary hypertension gets more severe, it allows the blood to skip the lungs and still get out to the body in times where the pulmonary hypertension is getting really bad, which can be protective or safe for that patient. So it does influence. We may be less likely to recommend closure or restricting that hole if we know they have SOX17 or another PAH gene. I don't know about you if you have a similar or different approach.
Yeah, it's exactly the same. I think the decision to close these holes can be so complicated. As you mentioned, I've had patients in which the reflex is to close the hole, but when the right side of the heart is struggling and there's really high pressures, like sometimes not only is it better sometimes to leave the hole open, but sometimes, in rare cases, like we might even create a hole, create an atrial septal defect, because what happens is it's like a pressure release valve. You're lowering the pressure, and patients sometimes even feel better with it. So it's complicated. One thing I wanted to mention is for those of you, if you've had genetic testing or, just be aware, like often what really changes when you get genetic testing is that you screen all the relatives. And so you look at all like first degree relatives. So those are parents, siblings, cousins, children, and then you screen all of them for the same thing. Because if you have a genetic mutation that's known to cause pulmonary hypertension, like the real benefit is for everyone else in the family too. You can screen earlier and maybe pick up pulmonary hypertension before it becomes severe, which I think is, really, really helpful. We have a little lull, so I just wanted to mention one thing. I had asked Dr. Kreitzer about diagnosing in children, and I just wanted to kind of add that for adults with pulmonary hypertension and congenital heart disease, it's kind of similar. We do echocardiography. Dr. Kreitzer's population of small babies and children, they're much easier to get very lovely pictures. I have bigger patients. Sometimes they may be obese or they just have surgeries, and it can be really hard to get nice pictures. And so sometimes if we think there's actually an obstruction, so there's something in the way of the blood flow, then we might do something like a cardiac CT, like a CT scan, or an MRI. And then what we have in common is that I always require a catheterization, because you just can't say that someone has pulmonary hypertension without a catheterization. It's the gold standard. It's like the test you absolutely need. And in like some institutions, like the ones who do this often, they may even check for reactivity. So we might test the person's lung vessels and see whether they respond to medication. It can be really helpful. So the diagnosis is kind of, similar in that way, I would say.
I'm so glad you mentioned that. We did have a question asking about how echocardiogram and right heart catheterizations compare in terms of accuracy for diagnosis of pulmonary hypertension and congenital heart disease. I think exactly as you mentioned, it can be a little more challenging to sort out exactly what is going on for patients with congenital heart disease because of these extra connections or flow that may be going from one side of the heart to the other. So that's why the echocardiogram can be a good screening test to identify patients with congenital heart disease or who might have pulmonary hypertension. That cardiac catheterization, that heart cath, really is important in getting a diagnosis and really understanding what's going on to guide treatment options. So that's an important part, and important to be aware of, that really is helpful for children and adults with congenital heart disease.
Yeah, and just to add to that, I don't know if you see it in kids, but I know in adults, sometimes patients are walking around with a diagnosis of pulmonary hypertension based on an echo, and the echo can make it look a lot worse than it is. It can also make it look better than it is, but I often find it makes it look worse than it really is. So
yeah, absolutely. An echocardiogram is a good screening tool, but it can't replace a heart cath. And just as you mentioned, there have been times where we've gotten fooled in thinking that someone has more severe pulmonary hypertension, and we do the heart cath and things look much better than we expect. And sometimes it's the opposite. It looks relatively mild and we do the heart cath and we're surprised at what we find. And in both ways are very helpful in knowing what we need to do to take the best care of them.
So I have a question for you that we came up with some questions in advance. So Dr. Kreitzer, how do echocardiograms and catheterizations compare in terms of accuracy for diagnosing PH in congenital heart disease patients?
Yeah,
you can answer for kids, and I'll answer for adults.
Yeah, it's a great question. So by echocardiography, we can get some measures that give us an estimate of what the pressures are on the right side of the heart. And in kids with congenital heart disease, if they have these extra holes or connections, sometimes it makes it easier to estimate the pressure on the right side of the heart. We can use how the blood is flowing across those holes or connections to give us an idea of what that pressure is. And that can make it a little easier than kids without congenital heart disease who may not have a lot of measures of exactly what those right-sided pressures are. The challenge, as we had mentioned, is that because of blood flowing from one side of the heart to the other, we don't know if the high pressures are just due to the blood flowing from one side of the heart to the other, or actually due to pulmonary hypertension. And that part, when we talk about the pulmonary vascular resistance, or how hard it is for blood to flow through those lung vessels, we really can't assess that by echo, and we really need to use the cardiac catheterization for those measurements. Dr. Plula, I don't know if it's a similar experience for you.
You know what I find is that I think in pediatric cardiology, everyone knows how to do a congenital catheterization because that's your bread and butter, like that's what you do. And I think I think that the complexity and the thoroughness of a catheterization in pediatric hands is not to not to say anything about adult, but like we just don't do it as often. A lot of adults who have heart problems are like older, they had heart attacks, they have, you know, other things. And so I find that the issue in adults is getting the echocardiogram and the catheterization performed and interpreted by somebody who is experienced in these conditions. And because I have found that sometimes people will be diagnosed with severe pulmonary hypertension and they just have pulmonary valve stenosis, which is a narrowing of the valve, and you treat it completely differently. Or they may not know how to interpret it. So I think the accuracy is very good. I think there's an issue with our sonographers, the ones who do the studies, who don't know how to get the right views. And then I think the catheterization is complicated because in adults, it's usually a very quick procedure. A right heart catheterization is like, oh, we're going to be done in an hour. And, you know, but in congenital heart disease in children, it's much longer. You need to, there's very a lot of nuance in it. So I think that's one of the issues that can be hard. Okay, we have a question. Transition of care. Yes, I love that question. And also surgical options in peds versus adults and how they aid in increasing life expectancy. So maybe Dr. Kreitzer can take both of those and I'll give an adult spin on them.
Yeah, those are great questions. I will say for kids, particularly when they're younger, you know, one of the options to treat the pulmonary hypertension may be to do surgery to correct the congenital heart disease. If we're able to close those holes or fix those connections, and that over time, that may be the best treatment for pulmonary hypertension. Again, depending on the specifics for each case. And kids are also other options for children who have pulmonary hypertension if it's not responding to the medicine the way that we would like. There are a couple of procedures that we can do to help as a treatment. One of those treatments is a procedure to actually create a small hole between the top chambers of the heart. As we were talking about earlier, that can be sort of a pop-off valve or a safety valve for children with pulmonary hypertension at times where the pulmonary hypertension is getting worse or not getting better, and the right heart is struggling to pump enough blood to the lungs to back to the left heart. That's a procedure that can be done with a heart cath. So we can do the heart cath to get the diagnosis and information and do that procedure to create that small hole between the top chambers of the heart all at the same time. The other procedure that is an option for kids with pulmonary hypertension with congenital heart disease that has been repaired is called a pot shunt. And this is a surgery to create a connection between the lung arteries and the aorta, the main blood vessel that takes the blood out of the heart into the body. And this is another way to create a pop-off or relief valve for that right heart. And in this case, the right heart pumps the blood out into the lung arteries, and then some of it skips the lungs and goes directly to the body. And that can be a good option for some children. Most of the time, that pot shunt is done via a surgery. In pediatrics, I would say that's done the vast majority of the times. At some centers and in some very specific situations, that can be done with a heart cath procedure. Dr. Plula, I don't know about your experience in adults and what surgical options or other procedures might look like.
Yeah, I think it's a little more tricky in adults sometimes because I will use the example. the examples of like an atrial septal defect and a ventricular septal defect. So an atrial septal defect, as we mentioned, is a hole in the upper chambers of the heart. In children who are otherwise well and have a hole and they seem to be good candidates for surgery, I think the decision to operate is a lot easier. I think in adults, we have found that the greatest benefit in terms of preventing complications is to close the hole before the age of 40. So I sometimes have more complicated cases in which there's someone who's like 50 or 60 and they have a hole, and I think the hemo, like they're figuring out like the blood flow and the pressures can be complicated. And sometimes we close the hole, but we poke a bunch of, sometimes we close the hole, but we poke a bunch of holes in the device that we use to close it, or we make holes in the patch that's the surgeon used to close it. So that is one thing that I think is interesting in adults, is where you close the hole, but like not all the way, and you allow for the pressures to improve. There are cases in which a patient has a ventricular septal defect or a patent ductus arteriosus, which are just they're holes or connections in the heart that are very high pressure, and so they can be associated with developing Eisenmenger syndrome, which is sort of a very severe pulmonary hypertension, is on this slide up here, in which you have the direction of the blood flow actually reverses from the left to the right to right to left. And when those patients, we don't close the hole because it's too late. Kind of like they do better with other therapies, like managing their symptoms and making sure that they don't have strokes and things like that. And so and sometimes there are a lot of congenital heart disease is so complicated. There can be different treatment options, but I do think sometimes a decision to fix what looks like a very simple hole can be more complicated than it looks. And then in terms of transitioning care, and then we have a couple of questions in the Q&A. The question, in children who have congenital heart disease or really any condition that requires long-term management, like at some point they have to graduate from the pediatrician. And back in the day, they never graduated, and now we, as a field, we think it's probably best for at least most of them to graduate. Wondering when do you like to have them graduate, and how do you guys do that? And then I can talk about how we do it, because we have a clinic for that too.
Yeah, this is a really important question and topic to think about. And we really take a long-term approach. And I will say every family is different and every kid is different. So it needs to be tailored to each family. But as kids become teenagers and starting into that young adulthood, we try and incorporate them more into their care in our clinic visits, talking to them more about what is going on with their congenital heart disease, their pulmonary hypertension, what are these medicines that they're taking, so that they begin to both have a better understanding and feel like they're taking more ownership of their care. And that happens over a number of years, so that by the time they're ready to graduate high school and go work or off to college, they're feeling more comfortable. For many of our families, we'll continue to see them through that transition. If they're going to go to college and they may be traveling to school and back, we'll see them until they're sort of getting settled and ready to make one single transition to an adult provider. For families who are staying locally, we'll do it in sort of a staged approach, where we will have them see our adult colleagues for a visit, and maybe they'll still see us for a visit afterwards to make that transition as easy and smooth as process. And it's very gradual to help them feel comfortable and sort of adjust to the differences. For families who may move either when they are still kids or who are moving when they're adults, we'll help them transition as best we can. Pulmonary hypertension is a relatively rare disease, and the community of providers who care for patients with pulmonary hypertension is also a very tight-knit community. So we know many of the providers at other centers, and we can call and discuss the specifics of their case to try again and make that transition as smooth as possible. Dr. Palula, I'd love to hear your experience sort of from the other side of that transition.
Yeah, I'm really I love this field of transition. I think it's so important. And one thing I want to mention to any of you who have children who have heart problems or any chronic medical conditions is that there's a big drop off in follow-up that happens around age 21, 22, or even or like actually more like 18. And that is what we're kind of talking about. We find that many patients have a gap in their care between the ages of about 18 and 26. And there's a number of causes for that. One is that when children are small, the parents are directing all the care, they're making the appointments, they're filling the medications, they're talking to the doctors, they are making all the phone calls. And there are some children in which they haven't done that. And then at 18, there suddenly gets handed over to them. And they may or may not, sometimes the parent will take over and continue, but sometimes they don't. And so there's that. There's loss of insurance, there's insurance gaps. And then the other issue is that just, the frontal lobe. So there's part of your brain that governs your ability to make decisions and plan and be organized. And your frontal lobe is not fully formed until about 25 or 26. So you take a kid who's never made appointments for themselves, doesn't know where the doctor's office is, has never asked questions in an appointment, and then you take away their insurance, and then you give them a lack of a fully functioning brain, and then they disappear. And the issue is that the other issue is that sometimes they think that they're cured, like they don't understand that they still have an issue, a problem that needs to be maybe just followed once a year, but they disappear. So that's why this topic is so important. And so in our we have a funny practice because I'm in a public hospital, so we have a luxury in one way that we see the patients together. So we have a clinic in which I see the patients with pediatric cardiology, and I see them every quarter for like a year or two. And so by the time they're ready to graduate, they already know me, and I'm not like a scary person, and they will make it to my clinic. One thing that I think, just for those of you who are in this position, I personally have found it very helpful when, as kids get older, like, high school is good to show them how to access their medical records on, the portal or the, online chart, show them how to make appointments. Like, how do you call? Because, kids these days, like, they don't even know how to be on the phone. It's like, you need to learn how to call, talk to an adult, make an appointment, how to manage their medications. And the idea being that the more engaged they are before they fall off the planet, when they go to college or whatever, the better the chances that they'll show up when it's needed, because what we don't want is patients who disappear and then at 25 they have a complication. It can be, really hard. The other thing I recommend is that they have a copy of their records on them. Like, there are things like health passports. So there's also, just an email that has everything on it that they save in their email, and they can show a doctor if they're ever in an emergency room. We have two in the Q&A. Okay. I am from TNT, where there's no specialists in pulmonary hypertension. My son's pediatric cardiologist hopes that with a promising result of the catheterization, surgery will be a possibility in the US. How do we navigate this? This is a tough question. Is there an opportunity to create PH knowledge sharing between foreign doctors and you guys? Yeah, the answer is yes, there's definitely knowledge sharing. I'm sure Dr. Kreitzer can inform better when it relates to kids. I can tell you for sure in adults, we have pathways for this. Generally, your doctor in Trinidad and Tobago would actually have to connect probably with the closest congenital heart disease pediatric center. It is generally really important to find a center that knows how to manage this. Like, it's a PAPBR is not, I don't think, that simple to fix. And I'm sure Dr. Kreitzer has more to say on this, but those are my preliminary thoughts.
Yeah. Yes to both of those, that there are absolutely opportunities to share knowledge, but there are also well-established pathways, and that starting with your son's pediatric cardiologist is the best, so they can reach out to a center that has experience in caring for kids with congenital heart disease and pulmonary hypertension. Oftentimes that process will look something like your doctor sharing the information from the medical record, including test results, can even be sending the images from an echocardiogram or a heart cath results if that's happened. So they can be reviewed by the center, and they can help make some initial recommendations of what they think is the best option. And if that does involve traveling to that center, they may need to do some of that testing again, just to really have a good understanding of what's going on at that moment in time. But we have had patients like this from other centers in the United States and elsewhere. So this is a common occurrence and something that your doctor should be able to help you navigate.
Yeah, it's really common in the big medical centers like where Dr. Kreitzer is, UCLA, Mayo, Boston. They all have, those are the four off the top of my head, they all have pathways where they do accept non-US, residents for surgery. One thing that you're probably going to want to do is talk to your insurance plan and figure out what your, if you have insurance there, is what the out-of-network coverage would be, because it's going to be something that's not covered within your network. So that's, but yeah, reach your doctor would be the contact person, or you can find someone and connect them to your pediatric cardiologist. But you're going to want to find someone who's well versed in this. I can handle this question: is CHD repair the only way to prevent Eisenmenger syndrome? This is you have the SOC17, and your cardiologist doesn't think you should, but your PH specialist is concerned about ES. You know what? I think the best thing in this situation is to see an adult congenital heart disease specialist, because this is like our field of what we do. There needs to be a bridge between your cardiologist and your PH specialist, and I think it's a complicated question. I mean, technically, yes, and if you not in a particular patient case, but generally speaking, closing a hole is the only way to prevent Eisenmenger syndrome. I think it's complicated in adults who have severe pulmonary hypertension and other stuff going on, in which case it's not so straightforward. I think in a situation where there's some complexity, I think it's helpful to talk to an ACHD, like an adult congenital heart disease specialist in your area, and then get another opinion, and they can kind of coordinate. It's not a super easy. It's not a straightforward question to answer. It really depends on the individual patient and particular pressures and heart function and things like that.
And then the
you
next
can take this as an
question.
adolescent question.
Yeah, speaking of adolescence, when a female patient starts puberty and has increasing estrogen levels, are there concerns with clotting levels being affected by PAH medications whose side effects include bleeding? And then during puberty, are estrogen levels managed via birth control, oral contraceptive pills? I think there's a couple of good points in there. One of those is that we know during adolescence, during that puberty, that we can see changes in pulmonary hypertension. So there does something about puberty that can have an impact on the pulmonary hypertension. And for some patients, we need to monitor them a little more closely during that period of time to make sure that their pulmonary hypertension itself is staying stable and that we don't need to adjust medications because of that. I think the second part of that, or the first part of the question that was asked, was about bleeding, and some of the pulmonary hypertension medicines do have side effects that can affect the blood counts themselves, or how some of the blood cells work and impact clotting. And so that when girls start to have their periods, they can have more heavy or prolonged periods. We have experienced that in some of our patients, and we have a great relationship with our OB-GYN team here who can really help counsel about what those birth control options are. It's also important to note that several of the PAH medications have risks for people who become pregnant and impacting the fetus. And so it's very important for girls and women to be on birth control if they're taking these types of PAH medications. It is important to know that we want to try and avoid estrogen containing birth control, because that type of birth control can increase risk of blood clots, but there are good options, including oral contraceptive pills that may be progesterone only, or other forms of longer acting reversible contraceptions. And we've had good luck with several of those options to help with either prolonged or heavy periods in girls who've started their periods and had those issues.
Like IUDs and stuff, like, is that?
We have, for many of our patients, we have recommended IUDs, which can be really helpful in helping to regulate and control periods and heavy bleeding. Looks like we don't have any more active questions right now.
That's right. I just want to say, coming here, this was fantastic. This was such a great and important webinar. Thank you both so much for being here and really like answering these questions, being able to pull out the additional questions that we received before the webinar and including them into your presentation. Thank you. We greatly appreciated. I know we have about 4 minutes left here, so I would like to give you both the opportunity. Do you have any lasting remarks before we wrap up for the day? And I do see we're getting some hearts and hand claps, so everyone is in agreement of how important this call was.
Well, thank you. I would just say thank you again for including us. This was a great discussion today, I think, on a very important topic, and we're so appreciative for PHA to helping to organize and put this together. And really appreciate all of the attendees and the folks who put questions in the chat to make the discussion better. We certainly hope that this was helpful for everyone and was able to share some good information about congenital heart disease and pulmonary hypertension. It's something that's very important to both of us. And so we look forward to continuing the conversations.
Yeah, thank you so much for having me. I've known about PHA for many years, and so it's my first time speaking at a webinar, and I just really appreciate the opportunity. And I love all the questions. You know, we don't know what is on patients' minds unless they ask. So knowing what people care about is important for the webinar, but it's also important for us as clinicians when we meet with patients. Knowing what folks want to know and how we can better assist. Because in the end, we just want everyone to do well. And, you know, PH can be scary. And so we just hope it's been helpful for some of you to just navigate like the landscape. Thank you.
Yeah. Thank you both, and thank you for joining for your first webinar. Hopefully this won't be the last time we see you in PHA programming. We do have podcasts and classroom videos, so hopefully we'll see you again there. Again, thank you, and the recording of this webinar will be posted within the next 2 weeks. You can look for it on the PHA Live webinar page and also receive it in our newsletters if you're signed up for that. So again, thank you everyone for joining us. Thank you for your kind words. Someone said in the chat that this meant the world. So we really, really appreciate you being here, and we will see you on the next PHA Live webinar. Bye,
Thank you
everyone.
so much.